Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Kathy Weinberg, RN. After receiving her nursing degree, Kathy worked at St. Barnabas Medical Center in New Jersey, where she worked in the trauma and burns unit. Kathy also taught nursing school for several years at County College of Morris in Randolph, New Jersey. She went on to become certified in critical care nursing and as a critical care nurse specialist. Kathy relocated to Fremont, where she works as a clinical nurse specialist in the Washington Hospital Critical Care Department and has over 30 years of experience in the nursing field.
Welcome and thank you for coming out tonight. As Vida said, I am a clinical nurse specialist. So what that means is I took extra training and I have an extra degree. And critical care is what I specialized in. So the patients that I primarily focus on are the sickest of the sick, and my goal is to help them get better and to help our nursing staff provide the best care that we can for anybody that's admitted to our unit for critical care. I work very closely with our intensivists, so the physicians who have special training to care for critically ill patients. And I also work closely with, of course, Vida, Diana Jaycox, our diabetic educator for the inpatient side, and Doctors Bindra and Kata also. So this is a very interesting topic for me. I hope that I don't breeze through it too quickly, but it's something that, I basically do every day. So we'll see. If you have questions, please don't hesitate to ask, okay? All right, so what are we going to review this evening? We're going to review the effects of diabetes on your body globally and what the implications are for a patient who is ill in the hospital, because diabetes management is different when you're at home than when you are in the hospital. Describe ways that you can partner with your healthcare team while you're in the hospital. It's very important for us to understand what it is that you normally do at home and what your normal routine is, so we can help you get back to that normal routine. It won't be normal when you're in the hospital. So it will definitely be different. We're going to talk about what some of those things are, which leads right into the next goal, which is to understand the differences between diabetes management at home and in the hospital. Okay? And then to learn about the typical plan to transition from the hospital back to your home plan for diabetes management. So just to briefly review diabetes, right? It keeps your body from turning the food that you eat into energy to fuel your body. And it can cause problems with your eyes, your kidneys, nerves, feet. Those are the classic areas that people think of. But it also impacts your heart and your blood vessels. Diabetes can cause changes in your immune system. When I say immune system, do you guys know, what would you call that? How you fight an infection, right? So diabetes impacts how you can fight infections. And that's one of the reasons that people come into the hospital, is because they have an infection. We ingest food, we eat it, right? It goes from our mouth all the way through that beautiful GI tract that we have. And as it passes through, the food, of course, is digested and broken down into very small particles the food is turned into glucose in the intestines, and then it crosses across the gut from our small bowel and our large bowel into our bloodstream. When we get that glucose in our bloodstream, then insulin is released, and the body says, hey, I need insulin. So insulin-dependent diabetes, or diabetes type 1, was the first one that I ever learned about, and that was when I was a child, much more prevalent than it is today. We've changed our eating patterns and our habits so much that now type 2 diabetes is much more prevalent, which is something that we develop as we age instead. We release our insulin, and it works like a key, which is why I have our lock and key here. So we have insulin that attaches to the cells and lets the glucose go through the cell wall. When the glucose goes through the cell walls, we now have energy, and we can do whatever it is that we want to do. So when I get home this evening, I hope I have enough energy left to take my dog for a walk. Normally, this is sort of what it should look like. So we've got glucose coming in, we've got insulin coming into our bloodstream, it's moving the glucose into the cells, and we have a fairly steady state, not a large amount of glucose in our bloodstream. But when we have diabetes, and sometimes even when we don't have diabetes, so this is really interesting, sometimes when patients are hospitalized, even if they don't have diabetes, they get treated for high blood sugar. We have lots more glucose accumulating in our bloodstream. So we've got lots more of those little purple blips in this diagram, or this pictorial, that are floating around. And so we end up with all the signs and symptoms of diabetes. So, and we're ending up with cells that are starved for energy, which is why most people feel tired or fatigued, right? They have to go to the bathroom a lot because the glucose carries the liquid out through the kidneys. So people pee more, right? They urinate more. Because there's not enough energy to fuel our system, so to speak, you're always hungry. I could do with, a little insulin maybe so I'm not so hungry. And then people will start losing weight for no reason. Then the other thing that happens, of course, is when I said the immune system is not functioning correctly, it takes longer to heal. People end up with more bruises. It takes longer for the bruises to go away. Of course, as we age, we have some of that same effect also. And then there's numbness and or tingling in the toes and the fingers sometimes. So when you're sick and you're having problems with your diabetes and your glucose is not well controlled, you may have some of these same signs and symptoms that you had when you initially were diagnosed with diabetes. I'm sure that you could all tell me the list of what I have here for how to manage your diabetes, right? The components of managing your diabetes include blood sugar management and monitoring, medications, diet and meal planning. I understand that Kim Alveri came and gave a really great lecture last month or the month before on diet and food, how to plan a good meal. Exercise is really important, and self-care for diabetes. And then we have ABCs of diabetes care, and that really is referring to the A1C level that you get measured on a regular basis, managing blood pressure, and managing cholesterol as well, okay? So, most important, right, what brought you to the hospital? That's going to impact to a great degree what kind of management the hospital healthcare team will provide to you for your diabetes or work with you for your diabetes. So if you have an infection, pneumonia, if you have an infection from another source, say maybe you stubbed your toe, you stepped on a nail, you cut your finger, something else happened and you have an infection or a wound, and congestive heart failure is a little bit different, right? Hyperglycemia, so if you come specifically for a reason that's related to your diabetes, that will be managed differently than any of the other reasons that might bring a person to the hospital, okay? Oh, I have a picture here also of a baby, right? I know one of Vida's passions is gestational diabetes, so diabetes that occurs during pregnancy, and that would be managed a little bit differently also than some of the other reasons that a patient would or a person would come to the hospital. We understand what happens to your body in general with diabetes. Now, if we look at what happens with diabetes and how it impacts you when you're sick, with infections, it completely interferes with what we call a white blood cell. So the white blood cells help eliminate an infection as best your body can on its own, as do immunoglobulins and T cells. So these are three really important cells in our bloodstreams that our body produces to fight infections. When someone has diabetes or their blood sugar is elevated, even if they don't have diabetes, it's much harder for the white cells, for the white blood cells, to fight an infection well, and they become less effective. Same thing with the immunoglobulins. Immunoglobulins are particularly related to allergic reactions, okay? And T cells are closely related to white cells and help fight those infections, okay? The other thing that happens is we have this fight or flight process that goes on in our body where you get stressed. So have you ever been stressed and you feel your heart racing and it's just pounding and you're like, ah, right? So that's part of that fight or flight response. Or you're really angry about something, or you feel like you need to defend your space against someone or something. That's that whole concept. What happens is your body releases glucocorticoids and epinephrine, catecholamines. All of those increase glucose production in your body. So when you have this fight or flight response that's going on to some perceived threat, whether it's a real physical threat or whether it's a stress that you feel internally about something that's happening, it increases the body's resistance to insulin. So it means it doesn't work as well as it should or could normally. And then, of course, as I said, it releases more glucose. So it makes our bodies produce more glucose than what we needed originally. Okay? Wounds and high blood sugar, as I alluded to before, we have slowed healing when we have high glucoses. Part of that is because of the glucose itself and the fact that it's not getting into the cell to help promote the healing. Part of it is because when we have elevated glucoses for a long period of time, then we have changes in our blood vessels, and the glucose can't cross the blood vessel as well to get to the tissue where it needs to be. It means also that the white blood cells that need to get across the blood vessel also can't get across as well. So they can't get to where they need to be in order to help fight maybe an infection that's there also. So everybody knows, or I hope everybody knows, that high blood sugar impacts your heart. It makes blood pressure higher almost 100% of the time. Anybody who has diabetes will also have an issue with their blood pressure, okay? It causes more catecholamines to be released, and it causes problems with something called platelets. Platelets are part of what help us clot. So when you cut your finger with the knife while you're cooking, or you poke it with a pin if you're sewing, or you accidentally, hit a nail when you're building something, whatever it might be, right? If you bleed, When that clot or that scab forms, platelets are involved in that, and the platelets are very important to how we clot. What happens with diabetes and high blood sugar is we have more clotting. We clot faster than we would otherwise. The last component for how diabetes affects our heart and is really important for what happens when we're in the hospital if we're sick is it can change our EKG rhythm or our heart rhythm. So, you know, when your heart speeds up or slows down, you may or may not be aware of that. But if you have an abnormal beat or an extra beat or something called atrial fibrillation, which is very common with diabetes and patients who have heart problems, you will feel different. And so with diabetes, it's more likely or more possible to have a change in your heart rhythm. So that's one of the things that we're watching for and monitoring if you're hospitalized. For the kidneys, which of course are extremely important, right? There's not one body system that I've mentioned so far that isn't important. They all have to work together. For the kidneys, there are changes to the blood vessels that are occurring in the rest of your body that impact your heart are also impacting your kidneys as well. And so we need to protect our kidneys, and so we need to monitor kidney function as well. Then the brain. This is a very interesting topic to me, but it's harder because of elevated glucose levels to concentrate as well as we would normally. You know, we want our glucose to be in just that right range. If you've ever experienced hypoglycemia or low blood sugar, you know what it feels like to have that, wait a minute, I don't really know what's going on, and maybe you pass out if your blood sugar gets that low, but it's hard to focus and things get a little fuzzy. The same thing can happen in reverse with an elevated glucose as well. So if we go back and we look at the components of diabetes management and we look at the 5 primary elements, blood sugar management and monitoring, medications, diet and meal planning, exercise and self-care, I'm sure you all have a specific plan that you stick to at home that helps you manage your blood sugars and your diabetes. And of course, you're following up with your physician for the ABCs, so the A1C, the blood pressure, and the cholesterol management, right? In the hospital, things change a little bit. And sometimes, and having been a patient in a hospital and having had my husband be a patient in the hospital, I can understand this question's really important. Who's in control? Sometimes it feels like you may have lost control when you're in the hospital. I thought this was sort of funny, you know. It's like, ah! Actually, that's how I'll probably feel when I have to deal with my 17-year-old tomorrow. But I'll feel like he's in control and I'm not. I'm the person in the bed, you know, rolling down the hill. Our goal is for you to not feel this way. We want you to feel like you are in control. I have up here a picture of our nursing professional practice model, and you can see what's in the center of that. And the green puzzle piece is the patient. For us as nurses in the hospital, one of the healthcare team members, putting the patient in the center of our world is what we're all about. And we want you as a patient, when you're in the hospital, to understand that. And that goes along with what our actual whole Washington Hospital ethic is, which is patient first. So regardless of whether it's a physical therapist, the diabetes educator, the patient who's monitoring, managing your care, the nurse, the housekeeper, the dietary aide, we're all here to try and make sure that you are put before everything else and that whatever your need is met, right? But unfortunately, sometimes it can feel like the patient or the person who's in the bed flying out of control down the road, right? Hopefully, after we review some of the things that happen when you're in the hospital this evening, if you are hospitalized and we have to change your diabetes management while you're in the hospital, it won't feel like things are quite so out of control. Blood sugar monitoring, I spoke about and have referred to a couple of different times, the A1C monitoring that occurs. So when you're admitted to the hospital, if it's been more than 3 months since you've had an A1C level checked, we will check that again. A1C monitors how well, or helps us gauge how well blood sugar has been controlled over the last 3 months because of the markers that attach to the hemoglobin that's in the blood. And so we want this value to be less than 7%, give or take, right? It really depends on you, what your individual circumstances are, and that's a goal that should be set with your physician, your endocrinologist or your physician that's managing your diabetes. Some patients do daily finger sticks, or what we refer to in the hospital as point of care testing. That's what that POCT stands for, so point of care testing. Some of you do these finger sticks at home. Some people with diabetes don't. When you're in the hospital, you will have it done, and you will have it done more frequently probably than what you have done at home. So at home, if you're monitoring, it might only be with meals and before bedtime, or it might only be in the morning, just to kind of give you a gauge for where you're at. The goal is always, when you're an outpatient, to at least be less than 140 for the results. But again, that's individualized, and it's based on you and your circumstances and what your total health picture is, and you should set that goal with your physician. When someone's in the hospital, we'll be doing blood sugar monitoring probably at least every 6 hours, or minimally with meals and before bedtime. If you are unfortunate enough to have to come into the critical care units and be admitted to ICU or CCU, we may be monitoring your glucoses as often as every hour. For the most part, most people who come in, they have pneumonia or they have some sort of infection, and we call it sepsis or septic shock. Then we'll be monitoring every 4 hours. But there are certain circumstances where we increase the frequency that we're monitoring because we're having such a hard time keeping the glucose level below 180 that we need to monitor much more closely so we can give more insulin, more medication to manage that and adjust the other things that we're doing, okay? There has been a lot of research that's been done in the last 10 to 15 years that has supported the fact that when someone's hospitalized, they will get better faster and have less complications if their glucose is managed more closely. When I started my nursing career, it was not uncommon for someone to have glucose readings that were in the 200s, and everybody be going, oh, that's fine, no problem, right? But we've learned a lot of things, and we have a lot more things to learn. And it's very important for us to manage that number, okay, while we manage everything else that's going on as well. Once a patient or a person goes from the critical care unit to one of the med-surg floors, or say the Institute for Joint Replacement, to that nursing unit, 140 would be a good level to keep the blood sugar under, because it's closer, right? We don't want to go the opposite direction and cause somebody to have hypoglycemia, which is just as bad and sometimes worse than having hyperglycemia, or that high glucose level, okay? So we're also monitoring and juggling things so we don't make somebody's glucose go too low. So what happens normally for people when we're sitting here, I'm going to guess that most of you have had supper before you came here. So if you look at the bottom graph that's here, you're going to see that whatever insulin you have that's being made by your pancreas still is peaking now because it's trying to catch up with the food that you ate, right? And then if you look at the upper graph, it looks at what's secreted on a regular basis without any food being given, right? So we have two components of insulin or natural management for food being ingested and glucose management in our body. One is, the upper one is what we call basal, and the lower one is what we call prandial or postprandial, so meal related. Medications that you use at home, will we use them in the hospital? Maybe, maybe not. It really depends on the individual circumstances and why you're being admitted to the hospital and how long it's anticipated that you'll be hospitalized. So most of the pill forms of medication, regardless of what class of medication it falls into or what the name of the drug is, most of them have a very slow onset and they have a very long half-life, which means they hang around in your body for a long period of time. So they're slow to take effect and they're slow to go away. That's perfect for when you're at home and everything's going well, but not necessarily good for when you're in the hospital. They're also dependent on digestive function or the ability of your stomach and your GI tract to be working and for food to be ingested and digested in a normal way. Because of course this is a pill, you take it in your mouth and it goes from one end to the other, and it's broken down and utilized that way. The other thing is that some medications, and metformin in particular is one of the medications that is an issue. For anybody who's having testing that might require, say, a CAT scan or cardiac catheterization that requires a dye, a contrast dye, so the physicians and the radiologists can see more clearly what structures they're looking at, that dye will interfere with what's going on with the metformin, or maybe I should say it in reverse. The metformin will interfere with the dye, and it interferes or it interacts specifically in the kidneys. So most of the time, people who need to have testing that requires this contrast dye, they'll stop their metformin before the test, and usually the physicians, and this is something that you should definitely ask, will tell you what to do and how to manage your glucose before that test. Sometimes when people are hospitalized and we're not expecting to have to do that testing, we won't have the medication stopped in time, and so we'll do other things. So we may give extra IV fluids, like lots more extra IV fluids, or we may give some other medications in order to help offset or counteract the potential side effect of the medication and the contrast dye. So that's a very common thing to have happen, okay? So now you know, right? When people are hospitalized with diabetes, regardless of whether they're on insulin at home or not, almost always they will end up having insulin while they're in the hospital. Almost always, okay? Maybe you've experienced that or you know someone who's experienced that. And as we reviewed on the previous slide, the reason that happens is because those medications that are used at home every day have that slow onset and they have a long half-life. It means it's very hard for us to change the dosage and adjust what's going on based on what's going on with your body. So almost always we use insulin and do some transition. We'll talk about that in a minute. So we usually use Novolog, which is very fast acting and it has a very short duration. So remember back to the green, or rather the blue, excuse me, graph that it had the peaks for the insulin that was peaking in the body when you eat. That's what we're trying to replace and mimic with this. So we call it mealtime dosing, nutritional dosing, or we will call it correctional if we're doing it more frequently than just with meals. We will also give longer acting insulin once things are stabilized. Say in the critical care unit, we don't really start a long acting insulin until someone's about ready to transfer out of the unit, unless they're fairly stable and in the unit for other reasons. So now we're trying to replace that steady state amount of insulin that the body normally produces. So if you're hospitalized and you come visit my unit, you will probably have at least the short acting started and then potentially the long acting before you leave us and go to one of the med-surg or telemetry units before you go home. The other thing that might happen if you are unfortunate enough to come visit us in critical care, I know I say that like we're really bad, right? But you don't really want to be that sick. So the other thing that may happen is you may have a continuous IV infusion of insulin. And that's so we can really keep track of what's going on with your glucose and keep it within a good range, so we can promote your healing and help you get better sooner. The other reason that we might give continuous IV insulin is, remember I said you have the fight or flight response? So there are some medications that we give to promote a normal blood pressure. So when people come in and they're in shock from a big bad infection, so we call it septic shock. If someone comes in that way, we will be giving medication to support their blood pressure because their blood pressure is so low. And that medication acts like, or is, in some cases, actually is, one of the catecholamines or the stress hormones that get released. So one of them is commonly called epinephrine. Our body produces it normally. And we will often give epinephrine to patients as an IV medication to help keep their blood pressure in a normal range, so it's high enough. Food in the hospital, of course, is different than at home, and that's no shame on our dietitians or our food service staff. They're great. I had the best salad today in the cafeteria. They're really wonderful here and always trying new things, but it's different than what you eat at home, right? And often part of that has to do with the physical state that someone's in and the fact that they might not be able to tolerate regular food. And we will be giving a clear liquid diet to make sure that, if somebody who has an upset stomach, they've been vomiting, throwing things up, that they can keep it down. But also we might be giving a clear liquid diet just so we can get some sugar in or glucose in, some fuel to help fuel the body and give some calories. Because the other problem is you don't want to fast for an extended period of time because that will be just as bad for healing as eating, too much or having too much sugar. We have, of course, a targeted calorie and carbohydrate intake. The nurses are recording this and reporting it back to the physicians and the pharmacists, which often actually medication management while you're in the hospital may be by a pharmacist instead of the physician, because the pharmacists are here many more hours of the day in the hospital than the physicians are. And of course, unfortunately, the schedule may be different. You're totally off schedule if you're a patient in a hospital, and nothing is the same. You might not get the normal sleep that you do. You might work the night shift, and now we've got you trying to sleep at night and be awake during the daytime, and everything is different. We would like for you to consult with the dietitian, and they will probably come and see you whether you ask or not. Exercise. This is a tough one because if you feel that tired and fatigued and not good, you don't feel like doing any exercise, right? And most people don't even think of the fact that when you have to sit up in bed, swing your legs over the side of the bed, and move from the bed to a chair when you're in the hospital and you've been sick for a while, that's exercise. And it's really important for us to help promote that and get you back to your normal routine. But obviously, we won't be doing much in the way of exercise, okay? Depending on what's going on and how long you've been with us, we may request physical therapy come and work with you for a little bit to help you gain some strength back. And self-care. Now, this might seem funny, right? But self-care is really important. One of the things that happens to patients when they are in the hospital is somehow the toothbrush gets lost, right? That is the worst feeling that I can possibly think of, is to not be able to brush my teeth. It makes me crazy. And you know what? It's really important for our health. Not only does it make you feel better, right? You know, like brushing your hair and washing your face and brushing your teeth. They just psychologically make you feel better. There actual or physical reasons that it's really necessary and important. One of the things that a lot of the research in the last 20 years has found is that by brushing our teeth while we're sick and not feeling well, it decreases the risk of us getting pneumonia while we don't feel good, while we're sick, regardless of whether the reason that we're sick has anything to do with our lungs or not. But brushing your teeth is very important in order to help prevent getting pneumonia. So we want to make sure that you continue to do this when you're in the hospital. Even if you end up intubated on a ventilator with a tube through your mouth into your lungs, the nursing staff should be brushing your teeth. So these are very important things for us to be doing. And if for some reason it's not happening, you need to remind us to make sure it is. Foot care is a little more difficult for us, but we want to promote good foot care and make sure that all of your hygiene, basic hygiene needs are met, right? We'll sort of prioritize some of those in the scheme of how ill you are and how much you can participate yourself as well, okay? And then again, we're going to look at the ABCs of diabetes care and look at managing, checking that A1C. We're not going to be able to impact that number while you're in the hospital, but we want to monitor and see where you are. Blood pressure, we want to make sure that everybody's blood pressure is controlled, it's in the right range, and that we are providing any hyperlipidemia, for the fancy word, right? Cholesterol, medications for cholesterol to manage high cholesterol. So what happens with going home then? So if you are on oral medication at home and you come to the hospital and we take those away and we put you on insulin, what happens next, right? So usually what will happen is when you go home from the hospital, if you have been taken off of your PO medications, the physicians may start you back on those drugs while you're still in the hospital, or they may decide to wait. But if you've been off of them for a while, they will probably send you home with insulin for a short period of time. It's very common because, remember, the PO medications, the pills that are routinely used, take a long time to kick in and take effect, and they stay around for a while. That's the good part of it, right, when you're at home. But it's going to take a while to catch up with the PO medications, with the pills. So there may be a transition period where insulin is used in addition to the pills. And then what happens is the physicians, of course, will ask you to come back more frequently to see them and or test your blood sugars more frequently and call them with whatever those results are, okay? And of course, I would like to make a plug for meeting with our diabetic educators, right? So, who's in control? What can you do as the patient? Well, first and foremost, it's you plus the healthcare team, and that's who's going to manage. So we're all going to be in this together. We all want to work with you to support what you normally do and get you well and get you home. And ways to do that are to inform us of what you do at home to manage your diabetes, and then ask questions. Ask questions. This is what I always told my nursing students when I taught nursing school. The only stupid question is the one you don't ask, right? So if you don't understand something that someone's told you, or it doesn't make sense to you, or it's contrary to what you've learned and understood previously, you need to ask the reasoning, okay? And request a visit from one of the diabetic educators or the dietitian if you haven't already been visited by somebody. Okay? So, that's what I have to share with you. Great, thank you.